Welcome back, class. In today's lecture, we're going to finish up chapter 14, which will only leave us chapter 15 to finish before the term's over. So as we get into the rest of chapter 14, one of the things we look at is the trauma that occurs in the spinal cord. Now, when you have trauma to the spinal cord, you can have a couple different types of functional losses. You can have a paresthesia, which is a sensory loss, or you can have paralysis, which is loss of motor function. Now, when you look at paralysis, there's a couple different types of paralysis that you can have. And the different types are going to relate to different parts of the spinal cord. When you look at flaccid paralysis, flaccid basically is the softening or lack of control. So when you have flaccid paralysis, there's severe damage to the ventral root or the ventral horn cells. Now understand, it's very important that you understand the distinction between these different types. Again, flaccid paralysis is damage to the ventral root or the ventral horn cells of the spinal cord. It's because of this, then, that the impulses do not reach the muscles, and there's no voluntary or involuntary control of the muscle tissue. And so it's going to be really important to understand this process as we get into the spinal reflexes. If you want to make a star or a notation to come back to this slide after we cover spinal reflexes, you may want to do that because it may help to clear some of this stuff up too if you don't understand it. But again, because we're damaging the ventral root and the ventral horn cells, there's no ability of even reflexes to go from the extremities up to the spinal cord and back out. Because of this, you end up getting what we know as muscle atrophy, which we've touched on before, is the shrinking or the getting smaller of those muscles. The second type of paralysis is going to be spastic paralysis. And spastic paralysis does kind of have that term spastic, and most people will think spasm. And that's really what is involved, because now we have damage to the upper motor neurons of the primary motor cortex. So this is going to be more into the brain tissue. When this occurs, the spinal neurons in the spinal cord and the extremities still remain intact. So because of that, there's still stimulation of the muscle due to reflex activity. However, you lose voluntary control of the muscle, but there's still involuntary control that occurs, again, due to reflex activity. So when we look at the spinal cord and we have injuries, one of the injuries that occurs is a transection. Depending on where this transection occurs, you can end up being a paraplegic, which means the transection occurred between T1 and L1 and really is only affecting the lower extremities, or you can end up involving quadriplegia, and this is where we have a transection in the cervical region. And obviously, because of the terminology quad, that's going to involve all four limbs. Now, a couple other issues that involve the nervous system as far as conditions go. We have ALS, which is also called the amyotrophic lateral sclerosis, again, also known as ALS, but also known as Lou Gehrig's disease. Now, ALS got its kind of claim to fame and brought more into the public eye just a handful of years ago when people were going through the ice bucket challenge. And so what ALS does is it involves a progressive destruction of the ventral horn motor neurons in the fibers of the pyramidal tract. So again, if you think about what nerves or what area of the spinal cord is involved, in this case, it's going to be the ventral horn. Now you have to think about what cells are involved with the ventral horn, and that is your motor neurons. So we have motor neurons involved at the ventral horn. And so when we lose the ability to control or utilize motor neurons, you basically are starting to lose the ability to control muscle tissue. And so that's why when you look at the symptoms, it's not necessarily a paresthesia so much as you notice a paralysis of certain aspects. So you lose the ability to speak, swallow, and breathe. And those are some of the more severe cases or severe symptoms that oftentimes will occur more to the middle to the end of the condition. Right now, death typically occurs within 5 years of diagnosis, although there are more and more treatments that are actually starting to prolong the life of those that have been diagnosed with ALS. We don't necessarily know exactly what causes it quite yet, other than what it affects, but it has been linked to glutamate excitotoxicity, the attack by the immune system, or in some cases, they think it could be both. And with that, let's make ALS our attendance code word for the day. So again, the attendance code word for today is going to be ALS. So now we start to look at some of the nerve plexuses. And so we are looking at where all the nerves coming out of the spinal cord, specifically our spinal nerves, are starting to come together. And particularly the anterior ramus of these nerves. And so that is what a nerve plexus is. It's a network of interweaving anterior rami of the spinal nerves. There are 4 main plexi that occur bilaterally, and these are going to include the cervical, the brachial, the lumbar, and the sacral plexi. Most thoracic spinal nerves and the nerves of C5 to CO1 or coccyx1 do not involve or do not become involved with a plexus. Okay, remember, the thoracic nerves are involved more with our sympathetic neurons. And remember, those sympathetic neurons really are involved from that T1 to T2 beginning point down to the L1 to L2 region. So mostly involving that thoracic spine. So the first plexus that we're going to take a look at is the cervical plexus. Now the cervical plexus involves the anterior rami of C1 to C4. Now C5 is going to contribute a few axons, but they're going to be very few and far between. What happens is as these cervical, or at this cervical plexus, as the nerves are created, you get this weaving of them. They're going to branch and they innervate the anterior muscles of the neck, the skin of the neck, and portions of the head and shoulders. One of the nerves that you do want to know out of this one is going to be the phrenic nerve. And the phrenic nerve is the major motor and sensory nerve of the diaphragm, and it receives its fibers from spinal nerves C3 to C5. Now in each plexus, there is going to be a few nerves that we do want to know. And in this case, again, the phrenic nerve is going to be the one that we want to take away from the cervical plexus. Now, one thing about the phrenic nerve that you are going to want to know, and specifically know, is going to be what fibers are involved. And in this case, again, it's C3, 4, and 5. And one way to help you remember this is going to be the phrase C3, 4, and 5 help keep the diaphragm alive. And that should help you remember that the phrenic nerve is the one involved in what it innervates. You can take a look here. This shows us all of the nerves that are coming off and how they join together. Some of these will be relatively complicated, complex nerves. Others are very simple. And again, in this case, we just want to know the phrenic nerve. We're not necessarily concerned right now with all the rest of them. Our second plexus is going to be the brachial plexus. And it's going to be formed from the ventral rami of C5 to C8, as well as T1. Now, oftentimes it will include C4 and T2. And it's going to give rise to the nerves that help to innervate the upper limbs. Now, when we look at the plexus, there are some major branches that are involved with the brachial plexus. We have the roots, which are basically made up of the 5 ventral rami of C5 to T1. We then have the trunks. And so as those roots come together, they form an upper, a middle, and or a lower trunk. From there, those trunks divide into divisions, which are anterior and posterior divisions. And then lastly, we have the cords. And the cords are made up of the divisions that give us the lateral, medial, and posterior. And that leads us into the combination of the nerves. And one way to kind of remember the order is really tired, drink coffee. So the R, T, D, and C of each of those 4 branches. So we take a look at this plexus here, and you'll notice that we have the anterior rami of C5, 6, 7, 8, and T1. You'll notice the anterior rami of C5 and C6 join to form this superior trunk. You'll notice C7 basically goes undivided and forms the middle trunk, and then C8 and T1 form the inferior trunk. From there, each trunk will divide into anterior and posterior divisions. Here we have the anterior division of the superior and middle trunks, and the anterior division of the inferior trunk. We then look at the posterior divisions of all three of these, and you'll notice that eventually those three posterior divisions are eventually going to form this posterior cord. From here, you'll notice that we have the lateral cord then and the medial cord. And after all this, those cords then will end up dividing into corresponding nerves that lead us to the musculocutaneous nerve. We'll notice that we have parts combining to form the median nerve. We have the ulnar nerve. Then you'll notice we have those posterior divisions that end up forming that posterior cord, and that leads us into the radial and the axillary nerve. And we'll talk about all of those nerves here on the next slide. Now, if we look at the brachial plexus and we look at all the nerves that come off of it, or at least some of the major nerves anyway, these cords or this plexus will give rise to 5 major terminal branches. And these 5 nerves we do want to know because they do serve as the major suppliers to the upper extremity. So our first one is going to be the axillary nerve. Now, the axillary nerve supplies the deltoid, the teres major muscles, and that also gives us sensory input from the superior lateral arm. The median nerve is involved in carpal tunnel syndrome. It supplies most of the anterior forearm muscles. It supplies the thenar muscles, which are going to be the muscles right to the thumb region, and the lateral lumbricals. It also gives us sensory input from the palmar side and the dorsal tips of most of the fingers. Now, it does not supply the pinky. The musculocutaneous nerve supplies us the anterior arm muscles, particularly the biceps brachii, and it also provides sensory input from the lateral forearm. The radial nerve is the nerve that goes down most of the backside of the arm. So it's going to supply most of the posterior arm muscles, specifically the example being the triceps brachii. It's going to supply the posterior forearm muscles, and it's also going to provide us sensory input from the posterior arm and forearm, as well as the dorsal lateral part of the hand. And then the last nerve of the brachial plexus that we'll talk about is the ulnar nerve. And it's going to supply the anterior forearm muscles, most of the intrinsic hand muscles, and it's going to also supply the sensory input from the palmar and dorsal aspect of the 2 medial fingers, meaning your pinky and your ring fingers. So you can take a look at this graphic. Again, this just shows where the brachial plexus comes out of, and then it shows the pathways of each of those nerves as they go down the forearm and into the hand. Our next plexus is the lumbar plexus, and it's going to rise from L1 to L4, and it's going to innervate the thigh, the abdominal wall, and the psoas muscle. Now, there are 2 major nerves that we're going to talk about regarding the lumbar plexus. The first one is going to be the femoral nerve. The femoral nerve is going to innervate the quadriceps and the skin of the anterior thigh and the medial surface of the leg. Now, when you see the femoral nerve, one of the things you should think of is femur bone. And since the femoral nerve is kind of innervating that part of the leg, and it's innervating more the anterior surface, the anterior component or the anterior muscle of the femur bone is going to be that quadriceps muscle. Now, the obturator nerve is a nerve that passes through the obturator foramen, and it's specific to innervate the adductor muscles of that thigh. And so its job is going to be the interior, the medial thigh muscles, which are responsible basically for pulling your leg from an outward position and trying to pull it in more medially. And so again, it's responsible for adduction. Again, there are several other nerves coming off of that lumbar plexus, but again, specifically, we're only referencing this obturator nerve and the femoral nerve. Here's the pathway as they traverse down the rest of the leg. Again, we're looking more at the front side, and you can just kind of take a look at this and follow the pathways if you choose to. Our last plexus is going to be the sacral plexus. And the sacral plexus is going to arise from L4 to S4. And it's going to serve the buttock, the lower limb, the pelvic structures, and the perineum. There's really only one specific nerve that we really talk about when it comes to the sacral plexus. While there are obviously numerous nerves, this one in particular is the most important, and it's the sciatic nerve. Now, the sciatic nerve is the longest and the thickest nerve of the body, and it's going to innervate the hamstrings muscle, the adductor magnus, and most of the muscles in the leg and the foot. The hallmark of the sciatic nerve, however, is that it is actually composed of two separate nerves that basically get bound together, and that's going to be the tibial and the common fibular nerve, and they end up splitting once you get just above the knee. So if we take a look at the sacral plexus, again, you can see where all of these divisions start to come off. And you can see that there are numerous nerves that are coming off of that sacral plexus. But we're really just looking at this sciatic nerve. And you will notice that it is combined of the common fibular and the tibial divisions of this particular nerve. And we can take a look at this graphic again as you see this sciatic nerve traverse all the way down the leg. And you can see right where it divides again, and that's right around that knee region where it starts to split off. And then obviously you're going to have the two divisions. The tibial branch, or the tibial nerve, is going to continue on down and really follow the tibia bone. The common fibular branches off and really goes down the outside part of the leg and also follows the fibular bone. From here we start talking about reflexes, and we start to do this as we've learned about the nerves. So now we're going to use those nerve pathways in order to signal our reflexes. So reflexes can be a couple different types. They can either be inborn, or what we consider intrinsic reflexes, which is a rapid, involuntary, predictable motor response to a stimuli. The specific examples that we often talk about, and are probably the most common, are going to be the patellar reflex, the Achilles reflex, and the Babinski reflex. Most of us really know what the patellar reflex already is, and it's where we hit the patellar tendon down by our knee, and it causes the knee to kick out as a response. Again, it's a predictable response. You don't really have control over it. It's what happens when you stimulate that part of the body. A learned or acquired reflex results from practice or repetition. An example would be driving skills, but you can also really look at things like even playing the piano, or sometimes you are able to just, your fingers just play certain things, whether you necessarily recall what it is or not. And those are just kind of learned behaviors, or in a sense, learned patterns that again are just kind of reflex based. So in order to understand the pathway of a reflex, we have to understand the components of that reflex arc. Now there are 5 components to a reflex and a reflex arc, or this neural pathway. We have a receptor, a sensory neuron, an integration center, a motor neuron, and an effector. Now the receptor is going to be the site of stimulus action. It's what your body detects or the change in a particular type of stimulus. Oftentimes, this is some sort of stretch or some sort of change in the stimulus that the body detects. This is on the afferent pathway. We then are transmitting that signal that we detected from our receptor, and we're transmitting it along the sensory neuron. Again, this is along the afferent pathway. And so it transmits this afferent impulse towards the CNS. Then we have our integration center. Now, our integration center is going to be within the CNS. It's either going to be monosynaptic or polysynaptic. Monosynaptic, as you probably can guess, means one synapse. Polysynaptic means multiple synapses. And again, this region is going to be found within the CNS. Oftentimes, it's found within the spinal cord and never really goes towards the brain. Our fourth component is a motor neuron, and it's going to conduct the efferent impulse from the integration center to the effector organ. And so basically, our integration center has processed the information the way it needs to, and now we're going to send the signal out along that efferent or the motor pathway. And our last component then is an effector. And the effector is the muscle fiber or the gland that responds to the efferent impulse by contracting or secreting a hormone. And this is essentially the point that we get the response that was intended by stimulating the receptor. So here we look at the graphic involving the reflex arc. Again, the reflex arc is the neural pathway that's responsible for generating the response. In this case, you'll notice that we have our skin, and so the skin detects some sort of change or stimulus, essentially, that is geared towards changing or getting a response out of the body. So our stimulus activates the receptor, in which we are now taking that change or that signal along the afferent pathway. You'll notice this is a unipolar cell in which we have the cell body located within our dorsal root ganglia. It traverses all the way into our spinal cord, which in this case is going to be our integration center. So it's going to be processed by inner neurons, of which we now are sending a signal back out along the efferent pathway. So now we're following the efferent nerve until it gets to our last component here, and that's going to be the effector. In this case, it's going to be a muscle that causes a contraction. You'll notice that at some point there's a little bit of a split off here, and we'll talk a little bit more about that as we get into the next component of the reflex. So how do we classify different spinal reflexes? Well, reflexes can vary and can also be classified in different ways. So some of the things and questions that we have to ask is the reflex spinal or cranial? Is the spinal cord or the brain the reflex integration center? Is it somatic or is it visceral? So what is the target or what's the effector? Is it skeletal muscle, cardiac muscle, smooth muscle, or a gland? Is it monosynaptic or polysynaptic? So do our sensory neurons synapse directly with the motor neurons, or are there inner neurons within that reflex arc? Is it ipsilateral or contralateral? And so we're looking at, are these receptor and effector occurring on the same side or located on the same side, or are they on opposite sides? And then lastly, is it innate or is it acquired? Are you born with the reflex or do you develop it after birth? So if we look at a few examples of a monosynaptic and a polysynaptic reflex, in this case, you'll notice this is a monosynaptic reflex because again, here is our stimuli detecting or making a change in our receptor. We detect it along that afferent pathway. And you'll notice here there is no integration or inner neuron. it simply comes into the integration center, and then it directly synapses again with the motor neuron. And that then traverses all the way back out and goes to the effector organ. We then look at a polysynaptic reflex. This reflex in the pathway is very similar to monosynaptic, except you'll notice one difference. Over on this side with a monosynaptic reflex, you'll notice there is no inner neuron. When you look at this side, you'll notice that that sensory neuron comes in, synapses with an inner neuron, and then further synapses with that motor neuron. So that's just the difference between monosynaptic being one synapse and polysynaptic being more than one synapse. So let's take a look at a few different types of spinal reflexes. When we look at spinal reflexes, we have to look at the stretch reflex, the withdrawal reflex, and the cross extensor reflexes. So a stretch reflex is a relatively simple reflex. It's the reflexive contraction of a muscle after it is stretched. And so the best example that we have of this is our patellar reflex. In the example of the patellar reflex or any other stretch reflex, the muscle spindles of the muscle inform the nervous system of a change in length of that particular muscle. And so our Golgi tendon organs also then inform the brain as to the amount of tension in the muscle and tendons. So we're not only stimulating the muscle spindles that detect the stretch in the muscle, but we're also detecting the tension that occurs within the Golgi tendon organs. So how does a stretch reflex work? Well, the stretch reflex is going to activate this muscle spindle, and then it's going to send a signal through the 2A sensory neurons. And they're going to synapse directly with alpha motor neurons in the spinal cord. These alpha motor neurons cause the stretched muscle then to contract. All of these stretch reflexes are monosynaptic and ipsilateral, meaning they all have one synapse and they all occur on the same side. Now, one of the other things that occurs during a stretch reflex is that we also experience reciprocal inhibition. And reciprocal inhibition means that we're going to not only have a stimulus going through one pathway, but we're also going to inhibit contraction of the antagonistic muscle or the opposite muscle that's being stimulated. We have type 2 fibers that are now going to synapse with interneurons, and they're going to inhibit the alpha motor neurons of those antagonistic muscles. So for example, in the patellar reflex, the stretched muscle is the quadriceps, and that stretched muscle is going to contract during that patellar reflex. So we have the muscle spindles and the Golgi tendon organs detect a change in tension and the stretch of the muscle and the tendon, and it's going to cause the quadriceps then to contract. While at the same time, it's also going to inhibit the antagonistic muscle, which is going to be the hamstrings, so that when you have a stretch reflex, you can only contract that particular muscle being stimulated, and so the antagonistic muscle is inhibited so we don't get a double contraction. Otherwise, we get no change. So here's our stretch reflex. Again, this is going to be the muscle fibers, in this case within the triceps brachii. And so here we have the receptor detecting the change, the muscle spindles and the Golgi tendon organs. We follow that pathway. This is going to be along the afferent pathway, where we have the cell body along that unipolar cell, all accumulating within the dorsal root ganglia. And then you'll notice that it comes in. The direct synapse with the reflex itself is going to be monosynaptic. So it's going to synapse one time with the alpha motor neuron that's causing the contraction. It's going to go out, cause a stimulus, and respond, or cause a contraction, I should say, of that particular muscle, in this case, the triceps. While at the same time, we also cause a stimulation of reciprocal inhibition. So It's not really a stimulation, but more so an inhibition. So you'll see here's the interneuron. We prohibit any type of contraction or any type of stimulus from occurring along this alpha motor neuron, in which case then we get no contraction of the biceps brachii in this case. So that when we go through the stretch reflex of the triceps, we are able to generate a contraction of the triceps, but nothing in the biceps. And that allows us to really test the triceps as an individual muscle and get nothing in the opposing or the antagonistic muscle. Now in this example, while it's not the patellar reflex, it's very similar to it. So instead of actually testing the patella and the quadriceps, we're actually testing the hamstrings. And so the hamstrings are actually going through the stretch reflex in this case. So here our hamstrings are being tested up here. The Golgi tendon organs and the muscle spindles detect the stretch in the tissue. So we now send that signal down through the sensory or the afferent pathway, where we now get stimulation or excitatory response in our pathways, but we also get inhibition in another pathway. So here's the excitatory stimulation pathway, where it'll follow this pink neuron on the bottom side all the way out to the hamstrings muscle. This causes the contraction of the hamstrings. At the same time, we get reciprocal inhibition along the other pathway, and that's going to cause the quadriceps basically to relax and have or go through a reciprocal inhibition where it will not be able to contract. And this causes a flexion of the knee when you're testing the hamstrings muscle. Our next one is the flexor and the cross extensor reflex. The flexor, also known as the withdrawal reflex, is often initiated by a painful stimulus, and it causes an automatic withdrawal of the threatened body part. This reflex is ipsilateral and polysynaptic. It overrides the spinal pathways and prevents any other reflex from utilizing them. And again, it's going to do this because it's often associated with some sort of painful stimulus or some sort of body part being threatened. And so it is essentially a protective mechanism. The cross extensor reflex then will often occur with the flexor reflex, and it does this within weight-bearing limbs to help maintain balance. And it's going to consist of an ipsilateral flexor reflex and a contralateral extensor reflex. And so what that means is that the stimulated side is going to be withdrawn or go through the flexor reflex, but the contralateral side is going to go through the extensor reflex. So for example, we look at stepping on a piece of glass. When you do that, you basically are withdrawing the foot that steps on the piece of glass, but you really have to contract the other side in order to help maintain your balance and really prevent you from falling over. So if we take a look at these reflexes then, you'll notice at the bottom here, this is where we have our painful stimuli. So the receptors detect the painful stimuli, they follow it along the sensory neuron, and that sensory neuron takes us up to our dorsal root ganglia where the cell body is, and then it follows it in as we synapse then with our interneurons. If we follow along with the sensory or the stimulatory pathway, I should say, along the ipsilateral side, you'll notice that it stimulates the motor neuron. We follow that red neuron all the way out, and it's going to stimulate the hamstrings muscle. And that hamstrings muscle is going to cause a flexion of that knee. We also, at the same time, in this case, will probably be getting hip flexion as well. But for our sake, we have this flexion of the knee, which is basically withdrawing that foot from the painful stimuli. If we come back up to the integration center, notice that we have stimulation then of a contralateral side or contralateral muscles. So if we follow that out along the alpha motor neuron, now you're going to notice that we get stimulation of the opposite quadriceps muscle. So we have stimulation of the ipsilateral hamstring causing a withdrawal reflex. But we get this extensor reflex of the opposite side, and that's going to stimulate the quadriceps, keeping that knee in extension and forcing us to be able to keep weight on the opposite non-affected side. And this is how the flexor and the cross extensor reflexes work together to withdraw something from a painful stimulus, but then to help maintain balance on that opposite side. And that will be the end of chapter 14.